A very good evening to all of you here. Thank you for joining us at CrownEdge. Today, the topic is going to be the development of occlusion from birth to mixed dentition. And I'm faculty for Pedodontics, Dr. Soundarya. So we'll be going through a lot of questions, and especially MCQs, which can come up for your NEET exams. A very good evening to all of you again. So let's look at the first question for today. Growth of the gum pads takes place in the A. First month of life, B. Second week of life, C. First year of life, and D. The first 4 days of life. So whichever option you think is correct, please enter in the chat box so that we can have a discussion about it. Okay, Prabhavati says first month of life. Anybody else who could give me an answer for this particular question? The first week of life, Varsha says that. Okay, right. So I'm getting a lot of answers, and most of them are choosing A, that is first month of life. So no, the answer is C. Okay, that is actually in the first year of life. So if you see in the compact stage, then obviously the child does not have any teeth. Okay, it's a very clean compact with which is pink, firm, and resilient. And the growth of the gum pad basically takes place in the first year of life. So by 6 months, the child would have started getting their teeth. Okay, so the maximum growth takes place only during that period. Okay, most children are supposed to get it by 6 months of life, but if some children they get their first teeth, before their first birthday or just somewhere around the first birthday. So maximum growth takes place only during that time. This is for the gum pad region. Okay. Now I'm going to talk to you a little about the landmarks in your gum pad. So there are many landmarks that you can see. So the groove between the primary canine and the first molar segment. Okay, this is very specific. The question is very specific. It's about the landmark between the primary canine and the first molar segment. It is termed as A. Gingival groove, B. Transverse groove, C. Lateral sulcus, which would be the correct answer here. Okay. So some of them have said lateral sulcus. Okay. Yes, the answer is C. It is the lateral sulcus. So now it becomes very important for you to know about the landmarks in the gum pad. In the neonatal period of life, that is especially with growth and development of occlusion, what you have to concentrate on is about gum pads, okay, and the landmarks in the gum pad, that is about the lateral sulcus, the transverse grooves, okay, and then also about what is the anomaly that could occur during this stage. I'll be posting questions about that quite a little later. This is just for your knowledge. You have the upper arch, which is actually horseshoe shape, okay, and the lower arch, which is U shape. So this could also be a question, all right. And it is usually the upper gum pad. Okay, if you notice in the picture, it is much wider and it is longer. So when a child is, closing the mouth, the upper gum pad basically encloses the lower gum pad, and then you see a uniform open bite that is there. And this open bite is considered to be very normal. In fact, it is what we call as your self-correcting anomaly. Okay, and then it is because of this open bite that is present, the child can actually suckle at the breast. Okay, so this is just a bit about the gum pad region. And like I said before, the gum pad is firm and resilient. It develops into two parts. Okay, now this is very important. One is the labial part and the lingual part. So I think you know about your development of the tooth part and all that in your oral histology lessons, right? So now that the gum pad is developing, there is one labial part and the lingual part. It is usually the labial part which differentiates first, and the lingual part differentiates the end. Okay. Now, because they both differentiate at a little bit different time period, you have one more landmark that is coming up there, and then it is then covered by a dense periosteum or a fibrous periosteum. Now, this is just a picture of all the landmarks that could be possibly there. Okay, and I want you to name A, B, C, D. I'm not going to give you the options here because then it would be too easy. Okay, Prabhavati, is my voice clear now? You said my voice is breaking. Is that fine? If there's any issues, you could please come up in the chat box and let me know what is happening. Right? Okay. I've got an answer says A is transverse groove. Okay. What is B? Okay. Okay. C and D. Okay. B is lateral sulcus. C. I'll just give you a minute so you can mark A, B, C, D. Okay. In the chat box, and then we can have a discussion about this. C is gingival groove. Okay, okay, you have to see where C is pointing from. Okay, C is the yellow arrow and B is the blue arrow. So they're kind of overlapped there. Okay. So this is the answer. A is your transverse groove. Yeah, I think we got that right. Okay. B is the dental groove. Okay. B is the blue arrow here. This blue arrow which is going straight. Okay. C is the lateral sulcus. A few of them have got it mixed up. Yes. C is the lateral sulcus and D is the gingival groove. So a NEET has a lot of your picture-based questions, right? So you have to be very, very careful as to what you are seeing, especially if it is something to do with your marking like this. Now, so yeah, I think this is pretty clear. So this is the lateral transverse sulcus or your transverse groove, okay? And you see, there's a one bump here, one more here, one more here. Okay, we just learn about what this transverse groove exactly is for. Okay, this is the dental groove, this is the gingival groove, and this is the lateral sulcus. So lateral sulcus, like in the previous MCQ that we had seen, it is just the space or the groove that is present in the region between the primary canine and your primary first molar region. Okay, so I hope this is clear. Now the dental groove is the, like remember I said the gum pads actually develop in two different parts. You have the labial part and the lingual part, and then they fuse in the middle. So that fusion is the dental groove. Okay, and each segment, which is a developing tooth site. For example, in this picture, I pointed out those bumps for you. Remember, I said this bump here, one here. That is your transverse groove. So the transverse groove actually represents where each tooth bud is present. Okay? So if you look at the maxillary gum pad, you have 10 such transverse groove, which corresponds to the 10 maxillary primary teeth that are going to develop. And similarly, in the mandibular gum pad, you're also going to have 10 such grooves, which is going to correspond to your 10 mandibular primary teeth that are going to develop in that region. Now, the gingival groove is what separates the gum pad from the palate. Okay, so this is the one. You need to have a definitive demarcation from the gum pad and the palate, right? Because everything is pink and firm there. So that is your gingival groove. Okay, and the lateral sulcus, like I mentioned before, is the space or the groove between the primary canine and your first molar region. Okay, I hope this is clear to all of you. Okay. So instead of having multiple questions, I have just put them as one single picture so we can discuss everything together. Okay. So moving on. This is a very interesting question. Gum pads contact each other in the area of A, second molar region, first molar region, C, canine region, D is option B and C. Is it first molar region or the canine region? Okay. Rupsi Gupta has given us an answer. Anybody else waiting to answer for this question? It's actually knee. Okay, it is in the area of your first molar region. Like I said before, the maxillary compound is slightly wider. Okay, and it kind of encompasses the lower compound, the mandibular compound. But they meet at one particular region, and it's the first molar region. Okay, and in the compound, if you see when the child closes the mouth, usually have a anterior open bite, which is very uniform, and this is what helps the child or the infant to suckle during this neonatal period. Okay. Now, this is related to the anomalies that could develop in the neonatal. So, like I said, gum pad region, there are no teeth present. Okay, but you do have some aberrations from that. So, the teeth that erupt in the first month of life are natal teeth, neonatal teeth, premature teeth, and precoccus teeth. So the question says erupt in the first month of life. So that is your keyword or your the part of the question that you should pay more attention to. So erupt in the first month of life. What is the answer? Right. It is a neonatal teeth. Okay. So I think this is pretty easy. And similarly, you could have another question. Teeth present at birth. This is very easy. If you get this, the previous one right, then you would get this one also right. This is the natal teeth. Okay. So usually a lot of you get confused between natal and neonatal. Uh, just remember, neonates are those children or those babies within the first month of life. They're called neonates. Okay, like how we have infancy, school-going child, toddler. Those depending upon age groups, your child is called differently depending upon their development and all that. A neonate is any baby which is in the first 30 days or the first month of life. We call them a neonate. Okay. So neonatal teeth, therefore, are the teeth that are present or that erupt in the first month of life. Now, if a child is born with teeth or at birth they have teeth, then that is known as the natal teeth. Okay. Now, these usually they have a very different etiology. So the question here is about etiology of natal and neonatal teeth. Is A, hormonal stimulation? Is it B, heredity? C, because superficial presence or position of the tooth buds in the gum? Or D, all of the above? So what would be your particular guess? A lot of you are answering D. It's very nice to hear. See this. Yes, D, all of the above is the correct answer. Now let's just talk briefly about this natal and neonatal. Yeah. Now, general predilection, according to Cates et al., is one of the authors. He said that it is present mostly in the female gender, and the basic etiology is it could be because of the superficial position of the tooth germ. It could be because of any malnutrition or infection that was there during the development of the baby. Okay, it could be because of a hormonal stimulation. Okay, most importantly, if you see, most of the times it is because of hereditary inheritance. Okay, the usually the grandfather or not immediately the parent, but usually some other relative in the family would give you a history of presence of this natal or neonatal disease, and that has been linked to the presence of a autosomal dominant gene. Okay, or sometimes some authors actually attribute it to the osteoblastic activity inside the tooth germ area. Okay, so these are the possible etiology as to why you could have a natal or neonatal. So this is a picture-based question, okay? And look at the picture very carefully, okay? And you have to concentrate on the blue circle that I've drawn, all right? And with this, the question is, identify the condition. A, ectodermal dysplasia. B, Riga-Feda syndrome. C, traumatic ulcer. D, bone nodules. Let me just go back to the picture once again. Okay, so you have some child with a gum pad stage probably. and you have mandibular incisor region. Okay, but what is more glaring here, or which is more prominent here, is the presence of a small ulcerated or a small uh, uh, ulcerated area in the tip of the tongue. Okay, that is what is drawing our attention here, and this is yes answer. Option B is the correct answer. Is the Rigafede syndrome. Okay. Yeah. Pramavati says ulcer is due to the eruption of the incisors. Very right. So let's just talk about this, briefly. Now, Rigafede disease was actually identified by Riga. Okay. He was an Italian physician, and it was described by Fede. So that's why they both have used their names and then a scholar. Rigafede disease or the Rigafede syndrome. Okay, but basically it is characterized by ulceration of the tongue, like that you see in the picture, and is often caused by repetitive traumatic injuries due to backward and forward movements of the tongue over the mandibular anterior incisors. So what happens is the child is born with these natal teeth or the neonatal teeth developed in the first month of life. They usually, most of them are breast feeding children. Okay, so what happens is because of the constant movement of the tongue over these lower incisors, what happens is it usually leads to a traumatic ulceration that is formed. So that is why in infants this is also known as traumatic lingual ulceration. Okay, the other name is sublingual growth in infants, and it's also known as traumatic atrophic glossitis. It is 1889 or 1881. So Rupsi Gupta has an answer. In 1881, it was identified by Riga, okay, but it was described by Fede in the year 1890. Yeah, there is a huge gap in the years, but he was the one who performed the histological studies on this lesion. Okay, so that is why he described it. But it was identified by Rega. So these are the other names of your Rigafari disease. Okay, and then clinically, it is commonly appears as an ulcer localized on the tongue. Okay, and although it is seen in other areas such as lip, palate, gingiva, vestibular mucosa, and floor of the mouth. Rupsi Gupta, yeah. Okay, she says in the book it is being given as 1889. This what I got is from an standard article, okay, about Rigafari disease. If you want, I can share that article with you. Okay. Uh, which book is this? Could you please tell me the name of the book so I could also go back and see? Could you just share that name of the textbook so that I know? See, one thing is that if you are referring any of these guides, but please be careful uh, and go back to the reference that they have given. Okay. Sometimes, you know, newer editions of book they keep changing their things, so we have to be updated. And some of the guides are, still referring to the older editions of the book, so we have to be a little careful. Okay. No, I'm just saying because most of the students use these guides, right? So we have to be a little bit careful. If you do get that part or that part which you say it is given in a book, please do share it with me so that we can verify which is the right answer. Because a lot of these MCQs, there will be multiple answers which is given by multiple people. So we have to know what is the right one. So let's go back. So clinically, if you see this Rigafari disease is actually seen on the tongue region. Okay. But although there are very rare occurrences, they can also occur in the lip, palate, gingiva, vestibular mucosa, and floor of the mouth. So basically, you have those teeth, and these teeth are not, blunt or anything. They're very sharp. They usually have very sharp edges. Okay, so because of constant movement when the child is suckling, they could lacerate your adjacent soft tissue, which is usually your lip or your palate or your gingiva or your buccal mucosa. And with natal teeth, you do have some syndromes that are associated with it. Okay, you have the chondroectodermal dysplasia or Ellis-Van Crumlin syndrome. Okay, the other is the oculomandibular dyscephaly with hypotrichosis. There is a Hallermann-Steffes syndrome. Okay, the other one is Pachynokia congenita. Okay, and also in some cases of cleft lip and cleft palate, you do see the presence of natal teeth. Usually, we associate cleft lip and cleft palate with oligodontia, but some cases have also noted the presence of natal teeth. Okay, I hope this is clear to all of you, right? So we can move on to our next question. So the appearance of natal teeth can be classified into categories given by which author. So you can know the name of the author here. A. Holt, B. Hebling, C. Boyd, D. Bodenhoff. So they have, I'm getting multiple answers here. E, A, B. Okay. The answer is B. Okay, it's Hebling. Okay. That is why Hebling has come up with a category or a clinical description of teeth. Okay. So these neonatal teeth, not all of them resemble your mandibular incisors, primary incisors, and some of them are different because some authors say that actually they are not your primary incisors, but some of them actually say no. In some cases, it could be your primary incisors itself that have erupted early in life. Okay, so if you just look at the teeth, you have to classify them according to Hebling's criteria. It was given in the year 1997. Okay, so this is Hebling's criteria, which says class 1 shell-shaped crown. Okay, poorly fixed to the alveolus by gingival tissue and absence of a root. Okay, so like I said before, these do not most of the case resemble your mandibular incisors. Okay, they just look like small little bumps and they are very loose. Okay, so because they are very loose to the attached to the gingival tissue, the chance of a child aspirating it during the suckling process becomes very high. Okay, class 2, some cases you see a solid crown. Okay, it's a proper crown, but it does not have root or there is very little root that is present. And again, it is held by the gingival tissue. So you can know how loosely it is be attached to the gingival tissue. Now, class 3 is eruption of the incisal margin of the crown through the gingival tissue. So you do not have a proper crown here. You just only see the incisal margin of the crown. Okay, and it is through the gingival tissue. Class 4 is edema of the gingival tissue, but the tooth is not erupted. So that you have an unerupted tooth, but when you palpate, you can actually feel a palpable tooth in that particular region. Now, class 1, 2 usually go for an extraction. Okay, it usually goes for an extraction. Why? Because one, the mother also will be having problems during breastfeeding. Two, the possibility of an aspiration when the child is feeding. Okay, and three, because these teeth are very shell shaped, do not have proper margins, the possibility of it lacerating the child's soft tissues is also high. So most of these cases, we administer vitamin K, and after it has been administered, we usually go for an extraction. Extraction is very simple. The only thing that we have to be very careful about is that because these two are very tiny and do not have any root, the chances of while extracting it getting aspirated again is a high possibility, and the child will be crying and moving around. So it is you have to very carefully remove these teeth. However, in some cases, clinically, when the tooth is erupted fully and it is very firm, we do not go for an extraction because in very rare of the rare cases, this could be actually your primary mandibular incisors which have erupted slightly early. Okay, so this is according to Hebling. Is it necessary to take an IOPA before extraction? Most of the cases, no. So your clinical judgment becomes very important here. you have to know what is small shell-shaped tooth, or something that resembles very less likely to be your primary mandibular incisors. Go for an extraction. We do we go for an extraction, and also if it is very loose, we always go for an extraction. But however, if it is very firm, and when you palpate or when you actually touch it and see, these teeth are firm, they have a root. In that cases, if you're very doubtful, it is okay to go for an IOPA, okay, for a lower mandibular IOPA. Of course, the child's cooperation and all that becomes very. IOPA becomes necessary if there is no enough mobility. Yeah, IOPA becomes necessary if there is no mobility. Yes, Group C is right in this. Okay, and so the IOPA, why you take it is basically to rule out if and see if there's actually another set of teeth that are present or tooth buds that are present, or to rule out to know if it is actually the primary mandibular incisors, or is it just a natal or a neonatal. Okay? So these are the aberrations that are the anomalies that you can actually see during your gum pad region or the neonatal period of life. Yeah, IOPA becomes necessary when there is no mobility. Yes. Okay. Now, from the neonatal period of your development of occlusion, we are now starting to move on to your primary dentition stage. The next set of questions that you're going to see is actually going to be I'm going to talk to you about the primary dentition period. There are again numerous changes that are taking place here. So the first thing is bomb. Okay, please remember this name. He is associated with, first to name the spaces in the deciduous dentition, who gave the keys of normal occlusion, both of the above, none of the above. Okay. So this name is, yes, A is the answer. Okay, Baum is actually the person who gave who was the first to name the spaces in the deciduous dentition. Okay. Now, if you look at the primary dentition or the deciduous dentition, you have two types. You have the uh, spaced dentition and the non-spaced dentition. Okay. Spaced dentition is the presence of physiological spaces between your primary teeth. Okay. And non-spaced dentition is when you have no gap at all. Okay, there is no absolutely no space. The teeth are all with good contact with each other. So Baum is the person who described or who was the first to name the spaces, and according to him, or according to the space dentition or non-space dentition, they actually play a very important role. These spaces are there, although they may look slightly off or anesthetic, not anesthetic, but they look slightly off. They play a very important role in the development of the jaws and the development during the primary. In your maxillary arch is about 4 mm, and the mandibular arch is about 3 mm. Now, with these spaces, they are also known as primate spaces. There are some spaces which have a specific name, like how you have lateral sulcus, in the primary canine and your first molar region. Similarly, somewhere around that region, we have a specific name for one particular space. So, coming to this picture, okay, look at the picture very carefully, all right, and tell me about the spaces that have been marked by the arrows. Okay, so your options are here. Identify the feature present in primary dentition. A. Primary spaces. B. Simian spaces. C. nasal spaces. D. Flush spaces. What is your answer for this question? This is a picture. I want you to look at the arrows. Okay. So your options are primary, simian, nasal, and flush. Yes. The answer is B. Okay. It is known as the simian spaces. Now, like I said, you have a spaced dentition in the primary dentition period. Okay. So all the spaces that are present are on a space. This any space that is present is known as a physiological space or a primate space. Okay. Now, one particular space or one particular space that is present is known as your simian space or your anthropoid spaces. So that space in the maxilla is the space that exists between the lateral incisor and canine. Okay, that is basically mesial to the canine, this particular area in the maxillary arch, and the space that is present distal to the canine and mandibular arch or between the canine and the first primary molar is known as your simian space. Okay, so maxillary arch, mesial to the canine, mandibular arch, distal to the canine. Okay, I think that is easy to remember, and that space is known as your anthropoid space or your simian space. Okay, so please do not get confused. Simian space is a type of physiological space of primate space. Okay, moving on. General characteristics of primary dentition are all except A. Flat or no curve of teeth. B. Vertical inclination of teeth. Slight overjet or overbite. And D. Presence of crowding. So the question says which is not a general character of your primary dentition. And the option or the answer, the correct answer is the presence of crowding. Okay. So basically, the dental arches are half round in shape. Basically, we call them as the Roman arches. Okay, and there is no curve of C. The curve of C is very flat. The curve of C comes into being only in the permanent dentition space, andros of occlusion. You have shallow cuspal interdigitation. Okay, slight overjet and overbite. Okay, and vertical inclination of your incisors, and there is absolutely no crowding. Like I said before, you have a spaced dentition. A non-spaced primary dentition will actually signify crowding permanent dentition. Okay, what is Hollywood smile? This is a term that has been come into use very recently. The perfect smile in a 7-year-old, okay? Gapless smile in a 6-year-old, smile seen in a child after the eruption of all primary teeth, facing same in a smile in a 6-year-old. Okay? What is Hollywood smile? Have you seen those Hollywood stars? They, if you have seen them, then they have a very nice smile, right? Like all their teeth are perfectly aligned. There is absolutely no crowding, no midlandastemas, no spaces. Okay, that is what we are referring to here. The answer is B. It is a gapless smile in a 6-year-old. So basically, we are talking about a non-spaced primary dentition, okay, which is actually not we do not want. We do not want a non-spaced primary dentition because it signifies that the child can have crowding in the permanent dentition phase. Okay, so that is what is known as the Hollywood smile. Moving on, like I said, the primary dentition again has a lot of things that you have to remember, and one of them is your terminal plane relationships. Okay. The terminal plane, which is favorable for your upper and lower E's, develop into a class 1 molar relationship. Is A flush terminal plane, B nasal step, C distal step, D none of the above. So it says which is favorable. Yes, I'm getting a lot of answers. Yes, B is the right answer. Okay, it is nasal step. Please do not say flush terminal plane, okay, because flush terminal plane actually does not lead to a class 1. Now, this picture shows your first flush terminal plane. Okay, so where the distal surface of your upper E and the distal surface of your lower E are in a single plane, right? So this is the flush terminal. And this is the clinical picture of that. So this is a favorable relationship to guide the permanent molars, but however, it does not lead them into a class 1. Okay. This is your, can you identify this picture for me? I think it is more clear here. Okay. The distal surface of your lower E is more distal. What is this? Yes, it is a distal step. So this step usually leads the permanent molar into a class 2 malocclusion. And this picture is more clear. Then this mesial surface is more mesial. So distal surface is more mesial. Okay, so this is a mesial step, and it is favorable to guide the permanent molar into a class 1 relationship. Okay, so we have a question. Okay, we have two questions in fact, very interesting questions. Why flush terminal plane should not lead to a class 1? See, a flush terminal plane will actually lead the molars into a end-on relationship. Okay, it will lead the molars into an end-on relationship. If that child has little bit of mandibular growth left and the mandible moves forward, then it becomes a class 1 relationship. First, if the mandible goes forward or if some amount of growth is left in the mandible, then it can move into a class 1 molar relationship. Okay. But if it is in a mesial step, this photo, if it is in a mesial step, when the permanent first molar are erupting, itself they'll be in a class 1 relationship. They will naturally come into a natural class 1 relationship. They do not have to wait for the mandibular growth to take place and then move to a class 1 relationship. Okay. One more question is that in mixed dentition, it was by Bagisha. Bagisha is asking, ma'am, in mixed dentition, we follow angle classification of first flush terminal classification. So it depends, right? So if you have your primary mandibular second molars in the jaw, then you have to classify them according to a primary classification. If you have the class permanent mandibular molars, you have to follow the angle classification. If both are present, then you do both. Okay? You say the molars are in flush terminal plane, and the angle classification is this class 1 angles molar relationship or class 2 angles molar relationship. If both are present, then you mark both or you write both as to what classification it belongs. The key to occlusion in the primary dentition is, what is the key to occlusion? That we have the key to occlusion in your permanent teeth is your mesiobuccal cusp of the mandibular, maxillary, first molar, and the buccal groove. Okay. Similarly, in the primary dentition, what is it? Yeah. Okay. So this classification or as to which leads to what type of occlusion, I'll be coming to it in the later slides. In fact, I have a couple of photographs. Okay. So with that, we can talk about it. Like I said, flush terminal plane end on mesial step class 2, class 1. Okay. So we will see as to how each thing takes place. Okay. That will come in the next few slides. So please be patient. We will deal with this question first. The key to occlusion in the primary dentition is, here we have B and B. The answer is B, distal surface of the mandibular second primary molar. Okay. This is what we have been looking into, right? This distal surface is what is very important. If this distal surface is more mesial, it becomes mesial step. If it is more distal, it becomes distal. Right. Early mesial shift is primarily contributed by. Question is very clear. It is primarily contributed by. Can you tell me the answers? Primarily contributed by. Early mesial shift is primarily contributed by the primate species. Okay. So what happens in a early mesial shift? Can anyone tell me? What happens in the mixed dentition area? You have two shifts. You have a early mesial shift and you have a late nasal shift. Okay. So in the early nasal shift, what happens is that your permanent first molars begin to erupt. Okay. And because of the force with which your permanent molars are sufficiently larger teeth, okay, the eruptive force is very high. Okay. So when they erupt, they basically push the erupt like this. The mandibular incisors, permanent molars erupt like this in the mesio-angular direction. So when they erupt, this is the surface of the second primary molar. Okay. So what happens because of the heavy eruptive force that is there, your spaces in the primary dentition begin to close, or that's your primate spaces in the primary dentition begin to close. So that is what is known as your early nasal shift. So primarily it is contributed by your primate spaces. Of course, secondarily, your growth of the mandible and the forward shift of the mandible also plays a role. Okay. So if the question said early nasal shift is contributed by, all of the above would have been the correct answer. But the keyword here is primarily contributed by, so it is right to choose the primate space. Late nasal shift, like I said, you have a second phase in your during the development of your mixed dentition. Okay, so the late nasal shift is because of your. Can you please tell me the answer? Okay. It is the leeway space of Nance. Okay, remember like this: L for late, L for leeway. Okay, you will never make a mistake again. So when there is no space, what happens is most children would have used their physiological spaces, or the primate spaces for the early nasal shift. Now, sometimes they do not have those spaces, and when no such space exists, the primary first permanent molar is not able to close the space. So, in these cases, the primary molar will exfoliate, and the permanent molar will migrate mesially to use up the leeway space of Nance. Now, the question can arise in your mind: what is this leeway space of Nance? Okay, can anyone tell me what is this leeway name space of Nance that I'm talking about? Okay. I will explain to you what this leeway space of Nance is in this particular picture. All right. So look at this picture very carefully. All right. You have the permanent molars, that is the sixes that have been marked. All right. You have your primary canine, your primary first molars, and your primary second molars. And beneath that, you're seeing your subsidiary teeth. Right. Now, what is this? This picture represents what? Yeah. I'll come to that. Just to answer this particular question, red and a blue line, and I'm talking about the mesodistal bits of the teeth. Yes. The answer to this particular question is the leeway space, and this is the leeway space. Let us look at it very carefully. You see those blue marks here, those blue lines. So it is the mesodistal bit of your C, D, and E. Okay. And do you see this red color line? And then there's a dotted line here. Okay. So this dotted line is actually touching the second bicuspids. Now, what does this mean? It means the combined mesodistal width of your C, D, and E is actually more than your permanent cuspids and your bicuspids. So this excess space, that space that you see between this blue line and this dotted line, the leeway space of Nance, and this is what is used up in your late late shift, late mesial shift. Okay, so we have always been taught, or we've always been taught to say that primary teeth are larger than our permanent teeth are larger than our primary teeth, right? Haven't we always been taught that? But here there is a difference. Okay, here the combined mesodistal width, I'm very specifically speaking about the combined mesodistal width of your C, D, and E is actually more than your permanent canines and bicuspids. Okay, so you're actually having more space in the primary dentition. So when the mixed dentition space is taking place, you actually have excess space in the maxillary and the mandibular arches, which is actually very required and gets used up. Is this part very clear? So that excess space is what we call as the leeway space of max. Okay. Is this clear, guys? Can I get a thumbs up or something on the chat box so that we can move on to the next concept that is there? Okay. Right. An 8-year-old child, this is a clinical based question, has a first molar in cusp to cusp relationship. Okay. And the treatment is A, fixed appliance, removable appliance, continuous recall and observe, D, none of the above. Okay. So you have an 8-year-old child, okay, in a cusp, but they are cusp to cusp relationship. It is better to actually wait and watch. Okay, so it is basically a continuous recall and observe. If in case after one point of time you feel the child is developing a class 2 or a class 3, then developing, okay, it's developing, not to develop the class 2 or a class 3, it is developing into a class 2 or a class 3. That is when you would want to intervene with a removable or a fixed appliance, depending upon other factors like maturity index and all that. Okay, so all this will come when we talk to you about preventive and interceptive orthodontics. But for this particular class, when I'm talking about development of occlusion, the best answer is a continuous recall and observe. Okay. Cone and funnel mechanism, very interesting. Okay, refers to A, transition of incisors, B, eruption of cuspids, C, emergence of the first permanent molars, D, none of the above. It's a cone and funnel mechanism. And when I'm talking about a cone and a funnel, what is that referring to? Yes, Rupsi Gupta, that's the correct answer. It refers to emergence of the first permanent molar. So what exactly is this cone and funnel mechanism? Okay. So basically, one is a cone, this is the cone, and this is the funnel. Okay. So in picture A, when the teeth are going to erupt like this, there is nothing to be done, right? This is the cone, this is the funnel. Okay, the lower molar is the funnel. So here it is going to get translated and fall into this particular. This represents your mesobuccal groove. Okay, this tip here. It's going to translate and it is going to come like this. Sorry. Okay. And here in picture C, there's less translation of the lower molar than of the upper. Okay, so basically this molar has to move. Okay, and in picture D is what we actually want. Okay, we want the occlusion to be like this. This is just a pictorial representation of your molar relationship, permanent molar relationship. Okay, so this mechanism has been known as the cone and funnel mechanism. So if it is a C position, right, you'll need a lesser translation of the lower molar than of the upper. Usually, the lower molar will, the upper molar will come and fall into its place. But here, you need the lower molar to move, and then the upper molar will automatically fall into space. This is known as the cone and funnel mechanism. Next, Yeah, we were talking about leeway space, right? Like I said, leeway space is there in the maxillary and the mandibular arch. So how much actually is this leeway space in the maxillary quadrant? The question is maxillary quadrant and not arch. Okay, so please pay attention to the question and look at the answer. A 0.9 mm, 1.8 mm, 3.7 mm, and 1.7 mm. So we're talking about a maxillary quadrant, that is one half of the arch. So the answer is A, 0.9 mm. So if you see the leeway space in the maxillary arch is total space is 1.8 mm. Okay. So when I ask maxillary quadrant, I mean half of it, which is only in one particular quadrant, that is 0.9 mm. So 0.9 mm on the right side, 0.9 mm on the left side. They give you a total arch leeway space of arch length in the maxilla as 1.8. Okay. Now for the mandible, it is more. Okay, it is 3.4 mm in the mandible. Now again, if I ask for mandibular quadrant, I mean again the half. There is 1.7 mm in on the right side and 1.7 mm on the left side. So see, these questions are very easy. Okay, now if you don't pay attention to one particular word, the chances of you losing an unnecessary mark becomes higher. Okay? When the question is easy, you have to be very careful. Patients of a 9-year-old girl are anxious of the spacing between her upper front teeth. Okay? 9-year-old girl and spacing between her upper front teeth. So these are the two things that you have to be worried about. What is the probable cause of this? A. Ugly duckling. B. Incisal liability. Developmental spaces. Measles shift. Yes, it is an ugly duckling stage that we are talking about. So how do you treat this condition? Do you use a removal appliance, no treatment, fix on orthodontic therapy, or do you go ahead with an activator? How do you treat this ugly duckling stage? Yes, go ahead with no treatment. Usually, it is a self-correcting anomaly that is seen in your mixed dentition. Okay, so you do not have to intervene or do anything about it. Now, it becomes very important to also know another part of this thing. Okay, midland asthma present in children is self-correcting if the midland asthma is not more than. So Jaydev, ugly duckling stage is it finishes when the permanent canines have erupted. So permanent canines usually erupt between 11 to 13 years of age. So ugly duckling stage usually ranges from 8 years to about let's say 11 to 12 years. I would give a range. Okay. Okay. Midland asthma present in children is a self-correcting anomaly if the asthma is not more than 2 mm. Yes. The answer is A. It should not be more than 2 mm. So if this child comes to you with a midland asthma of about 4 mm, 5 mm, or 3 mm, you have to be really cautious. Why? Because it could signify a lot of other things. It could be because of a frenal attachment, abnormal frenal attachment of the maxilla. It could be because of mostly, in most cases, it could be because of a presence of a supernumerary teeth that we call as a mesodens. It is in the middle, right? So that we call it a mesodens. Okay? So it could be because of that. So in such cases, when you see a diastema which is slightly more than 2 mm, you have to rule out presence of any of the muscular factors, I mean your abnormal frenal attachments. Okay, and you have to take a occlusion X-ray or a X-ray of the incisal region to find out if there is any supernumerary teeth present, or even a simple OPG, one shot. OPG can also be better, but it is better to take an occlusal radiograph because if a mesodens is present, then you know its relationship with the nasal floor and some of them it could be an inverted mesodens, it could be a normal mesodens. Sometimes you can even see the mesodens actually have erupted in some cases with a huge midland asthma. So that is when you have to start thinking about the other options. Which of the following causes changes in development of occlusion? A. Genetic factors. B. Trauma. C. Advanced caries. D. Muscular factors. E. Any of the above. E. Any of the above is the correct answer. How? Genetic factors, we all know that heredity plays a very important role in determining the occlusion. Usually class 3 and class 2, they have a very familiar tendencies running. Okay. Trauma, again, very important. If the child during the developing phases has had any maxillofacial trauma, then of course it is going to it is going to hamper the development of occlusion. Advanced caries. How does caries actually play a role in the development of occlusion? If you have advanced caries, especially like early childhood caries, what happens is you will lose a lot of your mesodyst width of the teeth. Okay, because of loss of those mesodistal width, your arch length becomes smaller. So therefore, accommodating the permanent teeth also becomes it is going to hamper your earlier mesial shift and your late mesial shifts. So it's going to eventually cause crowding, okay, or sometimes because of lack of space, it could lead to an impacted tooth, okay, or a tooth that has erupted, in infraocclusion or labally erupted or lingually erupted teeth. Okay? So that is how caries plays a very important role. How does muscular forces play a very important role? What role does a soft tissue have with your development of occlusion? See, muscles play a very important role. I hope you remember, yes, oral habits, very important. Because the force with which, that is created inside the oral cavity, again, instead of having a U-shaped maxillary arch, you're going to have a V-shaped arch. Obviously, if you have a V-shaped arch, it is going to give a lot of problems like development of your posterior cross bites and, all such things. Because again, your inter-arch space becomes very important and you're losing out on those. Okay. Not only oral habits, it could be any other habit, like even as simple as lip biting, okay, or even mouth breathing. Even your nose, the way if you don't breathe your nasal passages and use your mouth for breathing, and air passes through the mouth, it can leave a lot of malocclusions. Okay. Of course, they can be corrected if they are intervened at the right time. It is important for mandibular cuspids to erupt before the first and second bicuspid. Is this true or false? Read the question again. It is important for the mandibular cuspids to erupt before the first and second bicuspid. Is it true or is it false? It is true because what mandibular cuspids know, it is true, Roxy. I'll tell you why. Okay. For all those who said it is false, have you heard of something called intercanine width? Okay. Intercanine width is nothing but the width between the two canines. Okay. Now that plays a very important role because canines, as you know, are the cornerstone. Okay. And the eruption of the canines or the cuspids will actually lock the arch and aid in maintaining the child's potential arch length by preventing the lingual tipping of incisors. Now, what happens if incisors will tip? If the incisor tip, that is, they become retroclined, what is going to happen is you're going to lose your arch length. Okay, the overbite is going to get increased. So that it could lead to an abnormal lip pressure. Again, like I said, even the muscular forces play a very important role in the maintaining or the development of your arch. Okay, so it is true. It is better for the cuspids to erupt. That is why if you see the eruption formula, you have 6, 1, right? And then some books also give 6, 1, 2, 4, 3, 5, 7. Okay. This is 6 is nothing but the permanent first movers, 1 is nothing but your incisors, and so on and so forth. So it is better to go. It is better for the arch when the cuspids are erupted first before your bicuspids. Okay. I hope this is clear. In the mixed dentition, which is considered to be a self-correcting anomaly. Okay, I think somebody has a question. I'll just wait for you to finish and we will just look at this question. This is the last question for today's session, right? So in the mixed dentition, which is considered to be a self-correcting anomaly, unilateral loss of primary canine, definitely not good, because when you lose a primary canine on one side, what happens is your midline, your dental midline gets shifted. Okay, so it is actually not a very good thing. Lack of interdental spaces, like I said, non-space dentitions are again, they lead to crowding. Distal step is the correct answer. Okay, so C is the correct answer for this particular question. So when talking about self-correcting anomalies, okay, you have a list of self-correcting anomalies in each of the uh, stages. Like for example, in the gum patch stage, open bite is actually a self-correcting. The primary dentition stage, presence of spaces in the dentition is again a self-correcting anomaly. In the permanent dentition, presence of distal step or a Measles step or your ugly duckling stage. Okay, those are all self-correcting anomalies. Supervision of a child's development of occlusion is most critical at which option would you choose? Have to keep checking the occlusion at every stage of life, or is it very critical at one period? If so, which period is that? Is it 7 to 10 years, 11 to 14 years? The answer is 7 to 10 years. Okay. So this is also one of the guidelines by the Orthodontic Society. They say the child has to come or have his first orthodontic visit, or at least a visit to the pediatric clinic for the check of occlusion at around 8 years. Okay, why? Because most of the time, if you catch them early or catch a developing malfunction early, the chances of it getting corrected quickly becomes very, very higher. And for us, the mixed conditions period is a lovely period to correct a lot of things, lot of muscular problems, that is, abnormal tongue pressure, tongue thrusting, or your other oral habits like the thumb sucking, lip biting, lip sucking. It becomes very critical for us to correct it at this period of time, rather than wait and say no, you come directly to treatment. Let's look at it, at that time. No. Even after orthodontic treatment, sometimes you can see relapse because the muscular forces or your muscular habits have not been uh, kept in check. Okay, so yes, catch them early to get them corrected early. Yes. So the Ortho Society itself says you have to have a check of the occlusion at 7 to 10 years. Mandibular, even the eruption pattern. Okay, this is regarding the question about intracanine width. In mandibular, even the eruption pattern of 6, 1, 2, 4, 3, 5 is seen where cuspid erupt after bicuspid. See, in most of the cases, if you have opened readers and seen, you would have given or. There are two things. One is 6, 1, 2, 3, 4, 5, 7. Okay. Or 6, 1, 2, 4, 3, 5, 7. but the best way for it to erupt is 613,457. Again, children have different distinct. It could be because of, you could have an early eruption of your aspects because of there's a premature loss of your primary molars, especially second molars. Okay, and that and actually the canines should intracanine width increases because the width of intracanine width increases. There is more space for these teeth also to erupt in place properly. Okay, that is why it becomes very important to keep a check of the occlusion, especially keep a check of the caries status. Okay. We always, when it comes to us, we always think about not only just doing patectomy, putting the crown on the tooth. We always think about the spaces. Even 1 mm of space loss in the growing stages, so very important, plays a very important role later in life. It could save a lot of child to undergo orthodontic procedures if it is kept in check. So if you open mirrors, you're actually also given that 3 1 3 1 2 3 sorry 6 1 2 3 4 5 7 as one of your eruption patterns. The ugly duckling stage. We are back to the ugly duckling stage. It is characterized by all except deep overbite, distal axial inclination of your maxillary incisors, mandibular lateral incisors erupting lingual to the mandibular central incisors, and a possible overjet. It is all except so you do see a distoangular inclination of your maxillary incisors, that is your ugly duckling stage. You do see a possible overjet and a deep overbite. What you do not see is the mandibular lateral incisors erupting lingual to the mandibular central incisors, because ugly duckling stage is something that takes place in the maxillary arch. Okay, and we're talking here about your mandibular incisors and your central incisors. So C is the right answer. After 6 years of age, lengthening of the mandible occurs mainly at after 6 years of age, lengthening of the mandible occurs mainly at symphysis. Symphysis is this part of the region. After 6 years, between the canines, distal to the permanent molar. I'm talking about the mandible. Okay, so it is distal to the first permanent molar. Okay, why? Because you're going to have your second permanent molars that are yet to erupt. Okay, so your mandible has to slightly expand. You have your leeway space of Nash, which is going to easily accommodate your bicuspids and cuspids. So you need space at the posterior most part of the mandible. So that is by the that is distant to the first permanent molar. Okay. Right. So this is where your question about the flush terminal pain leading to end-on relationship actually comes into picture. So you have a child who shows a measles step occlusion of more than 2 mm. Okay, and the resultant permanent molar occlusion will be, very carefully read the question, measles step occlusion of more than 2 mm. What will happen in this case? Answer is B. It leads to a class 3 molar relationship. Let me explain how. Okay, this is distal step, right? This leads to a class 1, class 2 relationship. Okay, and because of the forward growth of the mandible, it can lead to a end-on relationship. You see 3 or arrows here. Okay, the red signifies shift of teeth, the blue signifies differential growth. Okay, and this green signifies, it looks like black here, but actually it is green. The dark green actually. It signifies forward growth of the mandible. This step most of the time leads to a class 2 malocclusion. But if there is a forward growth of the mandible, it leads to an end-on relationship. Now, we had the question about flush terminal plane or of EE, which is the most favorable to lead to a class 1. If you see the flush terminal plane, that FTP, most of the time, because the shift of the teeth or minimal growth, it leads most of the time to a end-on. Like I said before, only if there is some amount of growth left in the mandible and the mandible grows forward, only then you're going to go into a class 1. Which is how much percentage of the time? Less than 60% of the time. Okay, we need for class. What is primarily very important to us, if it is a measles step, then you're sure with the shift of the teeth and minimal growth, it leads to a class 1. But however, if it is more than 2 mm, this is another table that I have. Okay. Distal step. These are all studies that have been done for a very long time, okay? And on different individuals. And what they have found is distal step will lead to a class 2. The measles step is less than 2 mm, it leads to a class 1. Okay, in almost nearly 60% of the cases, that is 58.9, and is rounding it off to 60 for ease of remembrance. Okay, and 3% of the cases, if the measles step is more than 2 mm, it leads to a class 3 malocclusion. Okay, so here the question was, the child is having measles step, but it is more than 2 mm. So we have to refer to this part of the table. Okay. If the question was just measles step, what is this thing? Then you would go with the majority, which is the class 1 malocclusion. But here it is measles step more than 2 mm. So most of the time it would lead to a class 3 malocclusion. The term normal occlusion implies, what does it imply when I say normal occlusion? In the range of acceptable values, absence of recognizable malocclusions, functional aspect of occlusion is in place. D, all of the above. What do I mean by functional aspect of occlusion in place is that a basic idea of your occlusion is mastication, okay, speaking, speech. So all that is in place. It is not hampering your speech. It is not hampering your masticatory ability. So that is the functional aspect of occlusion. So when I see the term normal occlusion, or what I imply is it is in the range of acceptable values. There is no recognizable malocclusion. There is the functional aspect of occlusion is in place. So it is all of the above. Which is the following is not a self-correcting anomaly. Not a self-correcting anomaly. Spacing, retrognatic mandible, ugly stage, mature swallow. Spacing, when I mean spacing, it is spacing in the primary dentition, so it is a self-correcting anomaly. Ugly stage is a self-correcting anomaly. Mature swallow is not an anomaly. Okay, it is something that we all want to achieve when the child has moved to the permanent dentition stage. Retrognatic mandible, however, is not a self-correcting anomaly. So this is the table that I was talking to you about. Okay, and I said, right, in every period you have some kind of self-correcting anomaly. Okay, so this is that table. I think it is available in any standard pediatric dentistry textbook or a standard ortho textbook, because this topic is something that is common to both these subjects. Okay. This is available in most of the standard textbooks, something that you cannot miss. Okay. Right. So with this, we come to the end of our session. Okay. I hope you had an informative session, and I hope it is helpful for you for your exams. So you have to make notes about what the period, what takes place, especially especially the timing, and also be very specific with the spaces, that is the numbers, like 0.9 mm, 1.8 mm, and all that. So that you have to be very specific with that. So with that, I'm completing development of occlusion from birth to mixed dentition stage. Okay. I hope you had a very nice class. Thank you for your patience. Any questions? I can take it now, or you can always leave a message on the Telegram group so we can get back to it later. Thank you all. Thank you for your patience. And thank you for your